Yeah, thank you very much. Very pleased to be amongst you and with this opportunity to speak to this audience. So a wearable is what you do with it. It is like many things. Let us take a knife, for instance. You can hurt someone with it, or you can also use it to share a cake with a friend. So that's what ethics is about, those choices. Let's talk about ethics. Certainly, wearable devices have a great potential in sports, in healthcare, and maybe many other aspects. But when it comes to workers, the issue might be a bit different. We might have to be a bit more critical. The fact that the results of wearables devices that reveal individual health data may go, and sometimes apparently do go in quite some enterprises in USA, for instance, directly to the employer. That is quite astonishing from a Belgian and the European Union perspective. Rules of conduct, that is about how we want to live or work together in society or in a particular community. So the main reference point definitely is the Universal Declaration on Human Rights, that has been conceived as a worldwide basic and overruling reference set of values. In that Universal Declaration, there is an Article 23 that says everyone has the right to work, to free choice of employment, to just and favorable conditions of work, and to protection against unemployment. And you have many other kind of declaration charters, and sometimes also we see that ethical values and their concrete interpretation or concretization, they can de facto differ in different societies and in different communities with different traditions. But the general reference should be always, well, I think at least Universal Declaration on Human Rights. So then, given we have to just switch to the next, where we ask the first question. We have two main questions in this presentation. First is, are wearables that reveal individual health data, are they allowable or are they acceptable? But then we make distinction between three situations. First, as part of health surveillance by the employer, or as part of health surveillance by an independent occupational health physician, something which is very common in Belgium, certainly, and in many other countries of the European Union. And this is well structured and regulated. And the third one, as part of occupational health research by independent scientists. So, is the employer getting the data, or is an independent occupational health physician getting the data coming out of those wearable devices, or is it a researcher? This is not the same from an ethical perspective. We have developed in the past a concrete frame to make the analysis of ethical acceptability of occupational health practices in general. That can also be applied to these wearable devices. So, the ethical analysis is answering to the following questions. I first read just the questions in color. Who will decide? Upon what, for whom, why, how, and on what grounds? With which possible consequences for whom? And if the aim is to protect both health and employment of every worker, and in the meantime, also protecting privacy. So the first part is analyzing the decision-making process. Who will decide? Is it the employer who decides? Is it the worker, him or herself, who decides? Is it the occupational health physician who decides? And so on. And upon what they decide and for whom. Upon which wearable to wear, and what will be done with the data coming out of the wearable, and why is this option taken, and on what grounds is that option taken. Eh? That's the first part, to analyze that. Second part is to describe the broader societal context, with which possible consequences for whom. And then, of course, otherwise it will not be an ethical analysis. We have to assess compliance with predetermined concrete expression of fundamental values at stake. And that's the two at the bottom. First, a small comment on why is it so important if the aim is to protect both health and employment of every worker in my country and in the European Union. So it is part of the so-called social protection policy in the European Union. Social protection is a crucial value within the EU. Historically, it was the answer to the temptation of communism that was knocking at the door also of Western Europe immediately after World War II. The social security systems are just originating from that period, which are very highly elaborated in Europe. This does not mean that paradise is created within the EU, but it is an obligation for every member state to strive for it, a reference value to assess practices and regulations that has led to a much better social protection for the big majority of people. Europeans are therefore a bit astonished when many in the USA, they smell some taste of communism when we speak about social protection. For Western Europeans, it is precisely the opposite. Is that what stopped communism in that period after the Second World War? The right for work is a very strong value in the EU and even more so in Belgium. No selection of the fittest is allowed at all. I will come back to that. And if wearables would be used, for instance, for that purpose, that would definitely not be allowed. Now, regarding the second moral value, protecting privacy, a small story might clarify the importance attached to the privacy within the EU. Shortly after the collapse of the Soviet Union, as part of a European research project on ethical aspects of employee genetic testing, we also organized a workshop in Estonia with several participants from former Soviet countries. The question was, how would workers and employers react in your country if that option were offered? And the answer was, if the newspapers and the government say it is good, oh, so then it is good. There was not any sign of any critical consideration they expected to hear in their country. We then also went to visit a few companies to get a better idea of how health surveillance of workers was done in the field. And then it turned out that the individual medical records of workers were freely available to the employer. That was so under communist rule and not yet changed at that time, something which is unthinkable in democratic Western Europe. Medical records are part of privacy. Just because one lends his workforce to an employer for a fee does not mean that this employer has an immediate right to the employee's medical records, let alone other interferences with the employee's private life. In Soviet Union, privacy was limited to your own kitchen, bathroom, and bedroom. So we go from fundamental moral values to concrete rights. There's the right for access to employment and protection of health and safety. And for instance, in Belgium, this means that discrimination based on current or future health status is prohibited, which is much broader than just prohibiting and hiring of people for physical or mental disabilities reasons. And regarding the right for protection of privacy, so health data can only be shared by medical doctors and health professionals under their authority, usually under condition of consent, according to the General Data Protection Regulation on the EU, except in cases of explicit exception in that GDPR and in the national legislation and thus imposed by law. An example of the protection of privacy, wearables for geolocalization of workers are commonly not allowed in the EU, for instance, for tracing the bookkeepers of the enterprise. One cannot check if he or she has a particular tendency to talk to a favorite person during coffee breaks, for instance. On the contrast, it's possible for a transport company with trucks to tracing the truck, not to trace the truck driver. To trace the truck can be important for the organization of the company, for just communicating with the clients, but they cannot trace the truck driver, but the truck. But of course, the same wearable can also be used in a positive way to localize firemen who are just going deeply into a disaster, let's say. So the GDPR, that's the references of it, that's since quite some years, and it was generally modified, recently modified, where some major drawbacks were taken out and replaced by more intelligent articles. And so that is covering all that is exchange of personal data within the EU. be it for healthcare, for research, for transport, for public authorities, police, for everything. And that is, of course, freely available at the internet. And this, well, a typical example of the following question: when is political or social coercion justified? That's a question that should be added in order to just guarantee that values will be respected. So it should complete the decision-making process. When is political or social coercion justified? Well, one of the questions we can ask ourselves in that respect is, can informed consent be accepted as the only go, for instance, for occupational health practices in a context of power inequality, as for instance, between employer and employee? And that is definitely for the GDPR a no-go zone. It's not allowed. One cannot overrule regulations with an informed consent. One cannot just have access to private data one should not have access to with informed consent, because these are personal data that's part of the privacy regulations. It cannot be done with informed consent. Very simply. Sometimes it's to protect people against what they would agree to themselves. So this slide illustrates the different possible pitfalls of informed consent. So we can have, first of all, as said already, the status of the person providing the information when there is a context of objective power inequality or even a context of perceived power inequality. That makes informed consent procedures questionable. Secondly, it's not always clear what is the accuracy of the information provided. Sometimes I would like to be a fly and listen to when persons are asking for informed consent, how they explain what it is all about. And different persons may understand it in a very different way, as we know. So, and it's not always accurate. How to explain, for instance, for a polymorphic gene, what does it mean if one would test for it? It's hard to explain. Then the limited, the lack of correct understanding of the information is, of course, the next point. Will the person understand it, even if it's explained as good as it could be explained? And what is the ability to decide of the person? Is that person someone who just has the freedom to decide, or is that person in a position that he cannot be or she cannot be free to decide? Then also, when informed consent would be the regulatory principle, it could be that the decisional autonomy to consent of an individual may just be to the detriment of the freedom of other persons to consent or not to consent. And so there may be social constraints that make it really not just ideal to just regulate acceptability of practices via informed consent. And then there is also the complex interaction of personalities. We made an exercise with theater players that were given the respective role of a medical doctor asking for consent and a patient who was asked to participate in a research project as a study subject. And a psychologist gave different types of personalities to the actors. The actors were unaware of the type of personality given to the other person. And then we brought them into an improvised confrontation. It definitely demonstrated that not everybody, not each type of personality is suitable to give an explanation and obtain a real, authentic, informed consent. It's something we should keep in mind also when doing research projects. Now, what is an authentic consent? So these are all elements of questionable authenticity. What is an authentic consent? Authenticity implies free in decision to participate, but really free, equal in the relationship with the recruiter, be listened to and receive answers at the personal level of understanding, very important, and feel comprehended. That is what must be achieved in research. Otherwise, it becomes a purely administrative and implausible consent. Not talking about research, not about an employer asking to an employee, do you agree that you wear that wearable and I will get the results? That's forbidden in European Union. So while the principle of informed consent is highly questionable and not accepted in the US as a sufficient regulatory principle in occupational health matters, the same principle is very important when it comes to subject participation in scientific research. It allows individuals to participate knowingly willingly and enthusiastically. It is of great importance that researchers do this very carefully and thus do not create distrust or close the door for subsequent participation of the same subjects for other researchers also in other studies. As we all know, one can fool people only once. So, when it comes to research, there are also strict rules in the GDPR concerning the obligation to submit the project to an ethics committee. I will not go into detail there. And also regarding the secondary use of data, there are very strict rules regarding required anonymization or pseudonymization of data. Now, this slide is about how regulations regarding health and safety at work, and this also health surveillance regulations, are set up in the EU and in my country also. So there are tripartite negotiations with employers' representatives, trade union representatives, and public authorities representatives at different levels. Can be at European level, at national level, can be at also at the level of a particular industrial sector, at European level, at national level, and so on. When they are negotiating on which regulations should be put in place regarding health surveillance and health protection at work, they have to take into account all the data that you see at the left side. So like European Convention on Human Rights, European Social Charters, EU directives on health and safety, ILO conventions and constitutions, national laws, and so on. They cannot go around it. And then within that frame, they can so determine what is acceptable and not, and who can do what or cannot do, or can do something under certain conditions. So one could, all the documents on the left, one could summarize them as elements of social justice, solidarity, democratic participation, and respect for human dignity as a kind of 4 elements that constitute a basic value frame. Now, the triangle you see at the right, so we'll talk about the regulations coming out of that. This is the triangle again, and you see there are many disciplines involved in it. Employer is, of course, responsible always, even if the different disciplines can only give advice. The responsibility is only with the employer. They are responsible for the correctness of their advice on health and safety issues, but the employer is always liable. Of course, the social consultation, also at local level, also at enterprise level, is highly organized in Europe. Companies, even as soon as they have 50 workers, they must have every 4 years elections of workers' representatives that come into a health and safety committee. And it is an obligation of the employer to explain and discuss everything and every initiative he wants to take, which is related to health and safety at work, to discuss it in that committee. The employer decides, in far most of cases, of course, according to the regulations, but he must ask for the advice. And then there is of course, also the occupational health physician and collaborating health professionals. Now, when it comes to the evaluating and adapting the tasks and the working conditions, both at individual and collective level, that is a multidisciplinary task. Ergonomists are involved, industrial hygienists, safety engineers, psychologists, and occupational health physicians, of course, also involved. Now, then we have the pre-employment or pre-placement medical examinations, including the health anamnesis, which the employer cannot do, only an occupational health physician can do. I will come back to that. And the periodical medical surveillance, including biomonitoring, which is also a task for the occupational health physician. Now, the other professions have nothing to say in that. This is only a task for occupational health physician and collaborating health professionals. No one else has access to medical data anyway. So it's again, who decides upon what, for whom, why, and on which grounds. This is an elaboration of that principle here. So each company must either use an occupational health physician itself or a labor doctor from an external prevention service accredited by the Minister of Labor. So each company, as soon as they employ one single worker. The employer, as said, has no right to request medical records from the candidate employee or from the employee. Recruitment screening. Checking medical suitability may only be done at the end of the recruitment procedure and only by the occupational health physician and only for candidates who subsequently also have to be periodically medically monitored as prescribed by law because of the risks at work. So first they go through the whole procedure that assesses their fitness to do the work, not physical fitness or mental fitness, but their competences to do the work, to do the job. And only afterwards they go to the occupational health physician, which means that if they are not hired, then it means because they're not hired for medical reasons. And then people can go eventually to court if they disagree. It's not that the occupational health physician can choose between 3 or 4, which is the fittest. This is excluded. Unsuitability may be declared only for reasons directly related to the job or to special legal suitability requirements, for instance, a minimum length for policemen or policewomen. HIV testing and genetic susceptibility testing at pre-employment examination and afterwards also are prohibited unless authorized by special legislation. Employers' obligation to maximize an employee or prospective employee's work despite imperfections is crucial in the regulations. The labor doctor may suggest additional conditions if necessary to adjust work to suit the employee. And if the employee is economically inadequate, it is up to the employee to decide what to do, but never he can hide behind a kind of decision on fitness of the occupational health physician. The occupational health physician evaluates the compatibility of the work with the employee's health status and indicates whether the work should be adjusted and how this should be done without, however, mentioning the medical reasons for this. The labor doctor can only declare unfitness if there is manifest incompatibility. If not, the occupational health physician will advise adjustments of work or on workstation. And no communication may ever be made by the labor physician to the employer that contains medical information. They have to communicate with the employer via a standard form that states whether an employee is either fit or fit under certain conditions, should be sent on sick leave, or is unfit on the day of the examination. Termination for medical reasons is only possible under very strict conditions. And another important aspect also to make clear the concrete situation in Belgium, health insurance is not linked to the company. There is one generalized system for the entire population. So there is also, when people are not hired anymore, fired, let's say, there is entitlement to unemployment benefits. And also the occupational health physician can play no role in assessing the reasons for an absence due to illness. Now, there are, of course, also criteria for good occupational health professionals. Accessibility is crucial in that respect. Impartiality is a must and must always be reached. Protecting employees, that is what they should do. That's not a neutral choice. They should be impartial, but they should protect employees. And then professional competence, and which must be licensed and which is licensed, and that's licensed in interpreting health data, which is necessary. And why is this professional interpretation necessary and can this not be left to the employer, as is apparently the case in some companies using wearables? Let's take the simple example of a wearable counting heartbeats. How to interpret the relationship between heartbeat and the physical effort of an employee. Which individual variables may interfere with that relationship? If one cannot assess that, one cannot interpret the data. And what about doing the work in a different way? How might that affect that relationship between intensity of work and heartbeat? Another aspect is it could very well be that also insufficient heartbeat increase of heartbeat be indicative of a cardiovascular problem? So these are all elements. I say it in a very simple way, but you can all fill it in according to your own specialty. So it is necessary to know the person and to know the different variables playing a role and to being able to assess the physical condition of the person in order to interpret heartbeat data when doing physical work. Now, to summarize a bit this first part, so one of the goals of my presentation is also to draw attention to the tremendous importance of the context in which particular tools are used, and thus with which consequences for who. And this is a slight description of which is, let's say, the ideal, but generally this is the case, but not always, unfortunately, at the left-hand side. And what I was told from some situations in the United States, but I have no idea in how far this is generally the case. But let's take it abstract now, independent of where it is. There's a difference between a context in which occupational health physicians are present in huge numbers and must defend the right for the job, and a situation in which the employer would be the only one taking care, or who has to take care according to the regulations of the health and safety of the workers, and who has maybe selection of the fittest in mind, maybe. There's a difference between privacy and secrecy regulations, and when there are no strict privacy regulations or medical secrecy in an employment context. There's a difference between individual informed consent, which is at best a regulatory principle, and in a situation in a country with limited collective bargaining, and at the left-hand side, no individual informed consent possible when power inequality is the case, and when there is a highly representative system of social consultation sets strict rules that have to be followed, and the following of which is controlled. Then the dismissal regulations are very strict in Europe, while there is many at-will employment with no protection when fired in very many cases elsewhere. And then, as said already, there is the general health insurance system with high coverage, and there's the health insurance by a company that stops when persons are not hired anymore. And that is a very different context. And in order to make the full ethical analysis and also assessing with which consequences for whom, we have to assess that also. Now, we were talking about the acceptability. So are wearables revealing individual health data allowable or acceptable? And now there is another series of questions. Are wearables revealing individual health data a relevant tool? And again, we divide into three parts. Are they relevant as part of the health surveillance by the employer, or as part of health surveillance by an independent occupational health physician, or as part of occupational health research by independent scientists? That question should even precede ethical questioning. The ethical acceptability of something that might not make sense is zero. The answer to the question may again be different according to who is deciding upon what, for whom, why, how, and on which grounds. So, does a particular practice make sense? Is it relevant to dress workers with wearables to reach a particular objective, such as a better protection or better productivity? So, and here again, there are the three different contexts. Of course, they could be useful for surveillance by an independent occupational health physician, under strict conditions, of course. They could also be useful for researchers who want to study particular aspects of working conditions, for instance. But data coming out of wearables may be useless and even dangerous when interpreted and used by an employer who does not have the skills to interpret the data. I will try to illustrate this with a few examples. So first, to repeat, no ethics without science. Is it true? Does a wearable or a particular test improve us protection and or productivity through timely identification and remediation of potential risk factors? And does that work better than old approach to reach the same objective? And that should, I think, that's often forgotten, but should precede what follows, no science without ethics. So, and if it were true, should the test be done or the wearable be used? Is it acceptable from an employee's and the societal perspective? And that's the first part that I was dealing with already. But now let's go to this particular aspect with a few examples. Let's take this reasoning in 3 steps. Philosophers call that the thesis, antithesis, and synthesis. So a greatly increased heart rate may be an indication of inappropriate workload and the risk for cardiovascular decompensation. I think we all agree that this is true. Secondly, a wearable allows to continuously monitor heart rate of a worker. Fine, we still agree. And then we come to the conclusion, monitoring the heart rate of a worker with that wearable protects or will continue to contribute to protecting the health of the worker. Is that true? Big question mark. It sounds logical. It is the reasoning behind considering a particular wearable device as useful. And the moral pressure issuing from that reasoning is very strong. But is it correct? Imagine now that the results go to the employer. Imagine also that the employer is willing to select out those workers whose heartbeat is raising most when lifting things. And imagine also that persons can immediately be fired without reasonable unemployment compensation and in addition the loss of their health insurance. The worker may become very much worried and stressed. Then what is next? Give a kind of live band device measuring stress level of the worker. But what might happen is even more worrying, that the worker will take a beta blocker to reduce his heartbeat, when he knows that that would be a criterion for the employer not to hire him anymore. Then what is the gain? For who? Not to speak even about the liability of the employer. In case if he wants to assess the heartbeat of the persons, it could be that he will not see things that the medical doctor could have seen, and that then a person is getting a cardiovascular problem at the workplace. And then it might have consequences in terms of liability for the employer also. Let us take a second example. Same 3-step reasoning. Lack of alertness of a worker in a control room of a chemical plant might endanger lives. I think we all agree. And a wearable allows to continuously monitor cerebral alertness. It does exist. We cannot deny that it does exist. Now, the conclusion one could draw from that is that monitoring the alertness of a worker with a wearable prevents or will contribute to preventing safety problems at the workplace and big accidents and sevisos and so on. One could thread with many, many bad examples. So the suggesting that the non-using a particular wearable might have catastrophic consequences puts a high moral pressure on an employer to whom such wearable device is offered. But what about a worker whose alertness is followed via a wireless EEG headset? He might, of course, be worried about any possible revealing by or to his employer of moments of less alertness because he is afraid of dismissal. And what if he decides to tackle that threat and take, for instance, amphetamines or cocaine that increases his alertness? what will be the direct effect for safety of the company, and what will be the effect over time for the workers' health in that case. Having sufficiently experienced, well-trained workers in the control room seems the best guarantee to prevent problems and catastrophes. It reminds me also of the idea of only having one pilot in an airplane. And maybe that pilot would be full of all types of wearables, so to be sure that he is healthy, and what if he fails at one moment, there's only one pilot. So it's the kind of reasonings. I do it a bit in a too straightforward way, not with too much subtleties around it, but it's to make the point very clear. So what we do in those reasonings, in fact, is this. It's a kind of what we call in philosophy faulty logics. I can dress in my suit, I can put my suit in my suitcase, so I can put myself in my suitcase. It's the same type of reasoning. It's very dangerous. It depends, of course, on the size of the suitcase. And that's the context. At my age, when I've seen things before, good and bad, and certainly also belief in what new technologies can do and insight in what could be misuse of the same. It is like genetic selection testing based on genetic polymorphisms to prevent occupational diseases. Some people argued that this is a wonderful tool because then limit values would be the perfect solution when taking out the more susceptible people. We do not need occupational health physicians anymore, and we might even not need to lower the limit values anymore. This could be read in papers that were published in the 80s. In the meantime, we do know that this is not the way it works. And nowadays, wearables seems a little bit to be the new miracle tool. And we have to be aware of miracle tools because they do not exist. I'll take an example from the genetic polymorphisms. Again, the same reasoning. A particular exposure is associated with an increased risk for a particular disease. Yeah. At a collective level, this may be true. Antithesis, a genetic selection test allows the identification of persons who are more susceptible to the disease. Generally speaking, that could be true. Then the conclusion, well, it's already a bit tricky, the second one, but okay. In general, this is true. As an average, this is true. And then the conclusion, selecting out the more susceptible people allows to prevent the occurrence of the occupational disease in a meaningful way. So it was a similar kind of reasoning behind the assumed relevance of testing for genetic polymorphisms, indicative of relative susceptibility to disease outcome when exposed. Now, take this example. The left column, that's 100 persons, let's say, and 90% of the population that we can hire have low susceptibility to a particular disease, cancer outcome, let's say, when exposed to a particular substance X, Y, or Z. And 10% only have the wrong genes with a high susceptibility. And this is a kind of realistic relative risk. When one person, because it's not that they are not, it's not possible, well, it's not that they are not susceptible to the cancer when exposed. But 1 or 100 of the less susceptible will get the cancer after 20 years of exposure, let's say, very theoretical. While 3 out of 100 persons amongst those with the wrong variants of the polymorphic gene. So if we have 90% of the persons with the right genes and we have to hire 1,000 persons, and we make a test, a genetic selection test for that polymorphism amongst all the job candidates. We have to hire 1,000 persons. Then we will have, in total, 10 cancers after 20 years of exposure. And we assume that the test is perfect. And then when we do not do the test, because only 10% of our population has the wrong variant of the polymorphic gene, we will have 12. And what might then happen? That one has the illusion, because that's how people react. No nuance, but black and white. Oh, we have no problem anymore with that exposure. Less or no efforts will be made to lower the exposure level in the company. And the consequence might be that one will have more cancers, that also the less susceptible people will get more cancers than 1 out of 100, maybe 2 out of 100, or maybe even 3. So what's the gain? Nothing. These are wrong beliefs. Today we call wrong beliefs fake news, but often we are all susceptible to that, of course. So conditions for correctly predicting susceptibility to a particular disease, and thus theoretically, eventually, not arguing for that, but eventually selecting out the more susceptible people. One could theoretically do that if one knows all the characteristics that together must be of decisive importance if we test for those. That's not easy. Second, if all the susceptibility factors of concern are known, and this is often not the case. Very often it is based on just on a group basis. We see that amongst those who have bladder cancer after benzene exposure, they have that kind of polymorphism, and those who have not bladder cancer have the other type of the same polymorphic gene. That's at a group basis. But it's only one, while possibly, think of not benzene, but benzene. So, for instance, almost 10 enzymes are involved in making from benzene to a carcinogenic effect caused by the benzene. And each of them controlled by several genes. So in order to know the combination of genes that is really of genetic variables, of genetic variants, of polymorphisms, that is really making the person highly susceptible for having cancer after a particular period and intensity of exposure to benzene, it's almost impossible to find that out. Then, technically spoken, the carriers and the non-carriers must be distinguished correctly, which is not always that easy. Even if the tests to do that have considerably improved during the last decades, of course. But then a very important one, the relationship between the intensity of the exposure and the risk must be known for both carriers and non-carriers. It is shown in several studies. One Japanese study was the first one of Nakachi, and it did show that at low levels of exposure for a particular oat cell carcinoma of the lung, for people smoking very few cigarettes, the relative risk for people having the wrong genes as compared to those having the right polymorphisms was 7.3 to 1. At high consumption of cigarettes, that was almost 12 and almost the same for both. It was 11.9 and 12.1, if my memory is good. So if we don't know the relationship between particular polymorphisms and how this may manifest itself in terms of cancer outcome at different levels of exposure, then we don't know what we are doing if we are selecting out people with particular polymorphisms. And then the last one, sorry, I couldn't take off the light blue there. The intensity of the future exposure must be known. If we select out a person who studied for a chemical engineer, and he comes into the first chemical company, and he will be selected out because he is a slow acetylator, for instance, and not a fast acetylator. It might be that that person, after 1 year, would not be in the company where that might possibly be relevant, but that he might become the director of another department, another company where that exposure is not the case. And so we just crush the career of that person. And then he might just start enjoying whiskey, get drunk, and have liver cirrhosis every day get drunk every day and have liver cirrhosis after some years. What have we gained? So this is the type of total reasoning we have to make when assessing relevance of practices. So I think you're all quite familiar with this one. So assessing, that must be done for tests, for wearables, for anything. Accuracy, relevance, the necessity, and the consequences. Accuracy, that's validity, sensitivity, specificity, predictive value, you all know that. Reproducibility, reliability, the relevance towards the envisaged outcome. Need, necessity, which means, can the same objective be obtained by other means? That might be less intrusive. And the consequences. How does it affect employment, disease, accidents, productivity? How does it affect societal perception on employment-worker relationship, on self-determination, on privacy concept, etc.? So that's an analysis that should systematically be done regarding the relevance of the practice. A big series of elements have to be put together in order to assess relevance of a practice with a wearable device or other practice, other testing practice, and in addition, its ethical acceptability. This is very complex. We have to examine for each practice what is the added value, what can be the added value, and thus the relevance, and thereby start from the moral principles as expressed, for instance, in the ILO Convention 161 and in the Universal Declaration of Human Rights. We have to be clear on the ethical goals, on the moral goals, on the moral values. Otherwise, it has no sense to make an ethical analysis. Laying the scientific puzzle pieces is the task of the occupational health professionals. Laying the ethical puzzle pieces is a broad societal task, in which, of course, occupational health professionals should also be involved, because without their advice, one is talking in generalities and not concrete. In the European Union, this is entrusted to governments and to social partners to have this discussion. So, let us be mindful of the pitfalls of our own thinking when we set up or evaluate practices that, for example, should allow us to distinguish between suitable and unsuitable workers. It is not by using a single test or a few tests that are based on correlations on a group basis that one can predict an outcome for an individual. The puzzle is much more complex, and this is beautifully illustrated by this drawing by a Japanese artist. Look closely and you will see that the drawing is an impossible construction. And as professionals, we owe to human dignity the effort to avoid such constructions. And I hope that my presentation has a little bit contributed to that. Thank you for your attention.